Good afternoon, everyone. Thank you for joining us today as we come together to mark Crohn's and Colitis Awareness Week. This week is dedicated to raising awareness about inflammatory bowel diseases, particularly ulcerative colitis and Crohn's disease, conditions that affect millions worldwide and are yet often misunderstood. I am Sanjana Saxena, Associate Director Business Development at Phenomiqs, and your moderator for this panel discussion today. Our goal today is to shed light on these conditions, discuss the challenges faced by patients, and explore the advances in treatment and care. We're grateful to have diverse set of experts, all united by a shared commitment to understanding and improving the lives of those affected. The experts are going to talk about the clinical features, the current treatment landscape, the evolving treatment landscape, guidelines around AGA and how they are evolving, the role of artificial intelligence, and the role of nutrition in UC and CD today. Joining us in the panel today, we have Dr. Sampath Kumar, who is a consultant gastroenterologist and clinical lead at Doncaster and Bassetlaw Teaching Hospitals, NHS Trust, UK. We are also honored to welcome Dr. Jasdeep Singh Maan, who is a senior medical advisor at Phenomiqs Consulting. Next, we have Dr. Gursharan, who is currently the General Manager, Clinical Development and Medical Affairs at Biocon Biologics. And finally, we have on the panel with us dietitian Divya Tulsian, currently an independent clinical dietitian and an alumni of NIN Hyderabad. This activity is intended solely for educational and awareness purposes and should not be construed as medical advice. The views expressed are those of the panelists and do not represent the official positions of their current or former employers. Phenomics sincerely appreciates the valuable contributions of the panelists for sharing their time and expertise without any honorarium. So thank you so much, all. All right. Well, I would like to welcome you all, and just for our audience, together with our panel, we will be walking through a structured agenda that highlights both the clinical foundations and future directions in the management of UC and CD. Throughout, our panelists will bring their expertise to highlight not only what is known today, but also where the field is heading. My role will be to guide the conversation, ensure each perspective is heard, and keep us aligned with this agenda so that by the end we leave with both clarity and inspiration. With that, let's dive in, starting with Dr. Kumar.
Hello there.
So, Dr.
Thanks for
Kumar,
inviting me.
you're most welcome, Dr. Kumar. It's an honor for us to have you. Starting with a quick detailed introduction of Dr. Kumar. Dr. Kumar is a consultant gastroenterologist and clinical lead for gastroenterology and endoscopy for Doncaster and Bassetlaw Teaching Hospitals, NHS Trust UK. He also serves as the training program director for advanced gastroenterology training in South Yorkshire region in the UK. So, Dr. Kumar, since you are the practicing gastroenterologist amongst the panel and closer to witnessing patients' symptoms as well as complications, could you help us understand what are the clinical manifestations of ulcerative colitis and Crohn's disease, and how do you diagnose these patients?
Okay, so you start with a very big question, which itself will take maybe a whole day sometimes to discuss. So, concisely, ulcerative colitis and Crohn's disease are both different spectrums of inflammatory bowel disease, as we all know. But it's very important to distinguish between the two as to diagnosis, treatment, and the prognosis as well. Let's talk about ulcerative colitis. As the name itself, it's affecting the colon. Colon is a large bowel in our body, and that's why the inflammation of the large bowel is called colitis. So in ulcerative colitis, mainly people present with bloody diarrhea. That's the most common symptom. And they can have sometimes tenesmus and change in the bowel habits. Abdominal pain is a rare entity, but can happen. And in the Crohn's disease, we have to remember this can affect any part of the body from mouth to the anus. That means they can present in a variable fashion. And most commonly, it affects the small bowel and the large bowel. Those are the two most common causes, sites. If we're talking about the small bowel, people tend to present with abdominal pain and fatigue and sometimes abdominal distension. The large bowel inflammation in the Crohn's disease is called Crohn's colitis, and it's more or less presents similar to the ulcerative colitis with some slight changes. The other more important entity in Crohn's disease is the perianal involvement. That means involvement around the back passage. And this can be really disturbing to the patients. They get pain, they get discharge, and they get swelling. Now, these are the main manifestations, but we have to remember these two are the systemic diseases. So it can present with other systemic illnesses like fatigue, anemia, tiredness, and weight loss. We have to be very careful with weight loss, especially in a pediatric population. And we also talk about some extra intestinal manifestation of the inflammatory bowel disease, and they can affect the eyes, where they get inflammation of the sclera, uvea, scleritis, uveitis. They get arthritis, which is inflammatory arthritis. It can affect any joints, but mainly the small joints. And also the skin manifestation, which include rash, and most importantly, pyoderma gangrenosum. This is the clinical manifestations in a nutshell about the Crohn's disease and ulcerative colitis. Coming to
Thank
the
you.
diagnosis, you asked me about the diagnosis. Again, this is
Yeah.
again another big topic. For a clinician, it all, we all um, uh, focus on the history. So history is key, and in conjunction with our examination and investigations available. So after the history, we go to some biomarkers. There are some good biomarkers available, including free calprotectin, blood tests, including complete blood count, the CRP, which is the inflammatory marker. And in conjunction with this one, we do have endoscopy procedures. Without endoscopy, we cannot diagnose most of the time. So mainly the colonoscopy and entry into the terminal ileum, which is the small bowel. And we are always aided by the radiology imaging, and most importantly, MRI scan is much more widely used in the United Kingdom at the moment for diagnosis of small bowel Crohn's, any perineal involvement. The new kid in horizon in United Kingdom, at least, is the intestinal ultrasound. Already our colleagues in the rest of the Europe are very experts in this one, but in the United Kingdom, we are bringing in the intestinal ultrasound to diagnose these conditions.
Right. Right. Thank you, Dr. Sampath, for that. And we would also like to understand from you what treatment guidelines do you follow for UC and CD? What are the role of biologics, and how do you treat these complications associated with these two indications?
Okay. So again, this is always a big question for most of the clinicians treating the inflammatory bowel disease. It's not simple. Sometimes people ask, what's the best treatment? There's nothing like best treatment for any disease. And I'll come back to what we call personalized and focused treatment later. But we follow what we call British Society of Gastroenterology, which is our national body for all the gastroenterologists in UK, and we call it as BSG in a abbreviated. And this is they brought out a new guideline about inflammatory bowel disease only earlier this year, which comprises all the guidelines. And the main aim is emphasis is to treat to target approach and patient focused therapy in that one. And we are also in line with the other lines, other guidelines in Europe, which is called ECHO guidelines, and also what we call STRIDE recommendations. Now, coming back to ulcerative colitis, it depends on the severity and the location of the inflammation. If you talk with the ulcerative colitis, it can affect just the last part of the bowel, which is called proctitis, or proctosigmoiditis, or left side colitis, or pancolitis when it involves the whole of the colon. It also depends on the severity. Mild to moderate diseases can usually be treated with topical treatment of mesalazine, which is an anti-inflammatory medication, very well used, very commonly used in management of IBD. And in severe disease, we are going to do what is called top-down approach. So historically, people used to start slowly and then go up when the severity is becoming worse. And the thinking has changed that we want to hit it from the top if it's a severe disease and go, and reduce the medication if required. And in some severe cases, Steroids, whether we take it orally or intravenously, if they are severe, ill enough to come to hospital, is only, I always call it as a quick fix to the tell the patient it's a quick fix medication. It's not for long term. And then we have some immunomodulators historically, which are used in other conditions as well, and mainly azathioprine, mercaptopurine, and these are the kind of middle medications used to call. But we are next step is biologics. Biologics is the a big discussion at the moment, and we have various medications, including anti-TNFs, what we call JAK inhibitors, namely upadacitinib and tofacitinib, and IL-23 inhibitors, ustekinumab and risankizumab, and there's so many new medications in the horizon as well. And again, there's no single agent which we can use for single disease. It's all patient-centered, depends on the condition, and depends on the complications what we're dealing with. But in a nutshell, we have medications for a mild to moderate disease with oral agents, and for severe disease, we go towards biologics.
Right, right, Dr. Kumar. Um, thank you for that. Those are great thoughts there. And we would also want to know from you what is the prognosis and outcome with the current treatment options and what unmet needs exactly exist for UC and CD with the current therapies available.
So the prognosis has changed over the years. As you know, when the Crohn's disease and ulcerative colitis used to be diagnosed maybe 20, 30 years ago, we still see very rarely some of these patients in our clinic. Almost all of them had either an operation or they've been on some oral aminosalicylates, what we call methylazine, for a long time. Then came infliximab, which was the master of the treatment for a number of years, and now we have numerous medications. So this has changed how the prognosis is, and prognosis is getting better day by day. But we also remember that the disease, how it behaves, is also changing, and it can be severe as well. But overall, prognosis is much better with the use of new biologics, structured approach, and most importantly, multidisciplinary team approach for a patient. It's just not a doctor treating the patient. We need a number of colleagues, including radiologists, surgeons, our dietitians, our what we call IBD nurse specialists, who are the who have got a key role in education and looking after these patients. So numerous patients, to name only very few. And see, the unmet needs, like any other disease, is still predicting the response and personalizing the treatment for each patient. And again, we have to see that the disease changes from time to time in the same person. So that's one of them. And again, we get some complications, including fibrotic strictures, and how we can reverse this one, using medication. Again, a big question, and usually they end up having surgery at the moment. And the new thing which some of my colleagues are involved in research is addressing beyond the symptoms, that quality of life. That's really important. And depending on the health system where we work in the part of the world, equity and to the access and how people can get benefited, it all different works differently in different systems, and nobody knows the long-term safety of these medications. So that's another worry that everybody faces. What is the long-term worry? And as we know, some of the disease-modifying agents that we used to use, like azathioprine, have got a risk of lymphoma. And the biologics have got a risk of reactivation of tuberculosis, for which we screen everybody, but nobody knows the long-term safety.
Right. Right, Dr. Kumar. Thank you. Thank you for that. Lastly, we want to know what, in your experience, is the role of artificial intelligence in the future care of both UC and CD?
Okay, artificial intelligence, everybody's talking about at the moment. But my personal opinion, I just want to make clear that it's not going to replace the human beings. Okay, so we need to bear in that mind. And it has to be used as a good agent rather than replacing any established system at the moment. And as we know, AI is not going to treat patients. It's going to be important in diagnosis and the risk stratifying. So if you put a lot of data into AI, it's going to tell us, what could be the future. So it's going to be playing an important role in research, diagnosis, and risk stratification. And the other one is it may be able to help us in predicting the treatment response. And all again, it will all be evidence based. What we used to do called research, the AI might be able to do it in a simpler way, and it's going to only predict. It's not going to say anything, but it is going to have an important role in monitoring the patients remotely. So patient doesn't need to come in. Just to give an example, we do have a service in some of the centers in UK where people get fecal calprotectin kit at home and they upload it into the app, and people monitor it remotely. And if anything happens, the app has got a built-in artificial intelligence which will alert the clinicians and the IBD team about the abnormality, and then we can act on it, because we can't be keep looking at each patient every day. So that's where it's going to be. And we, the other important role of AI is going to be using as an adjunct in investigations. So there are already talks in radiology whether it's already reporting. In India, just for a change in our hospital, they started introducing reporting of the CT scan of the head through AI. But I don't think that's going to replace the radiologist. It's only going to say there's something abnormal, and the radiologist has to go back and have a look again. In endoscopy, AI can be a useful adjunct. We have to remember the long-term ulcerative colitis and Crohn's disease affecting the large bowel can lead to dysplasia, which can lead to the bowel cancer. We do bowel cancer surveillance in all these patients, and using an AI which can show us if there's any abnormality during the procedure. So we're already using the AI in endoscopies. When we come back, when we withdraw the scope and during the colonoscopy, it will highlight if it thinks that is there any abnormality. Again, it's not going to diagnose anything and it tell us what is there abnormal. So like that, it has got various roles, but has to be used in the right conjunction by the right people.
Understood. Understood. Thank you, Dr. Kumar, for all your thoughts. This was really insightful and helpful. Thank you.
Thank you.
Okay, building on that, we will move to Dr. Maan. And he is a physician with a unique blend of medical expertise, clinical research, and extensive experience in pharmaceutical consulting, distinguished by commended performance as a senior medical advisor. Dr. Maan comes with 25 plus years of clinical experience, including 10 plus years in pharmaceutical consulting, and has held senior advisory roles at global consulting firms. He has also been an ex-research fellow in the gastroenterology department at the Johns Hopkins Hospitals, US. So thank you, Dr. Maan, for joining us today. With you, Dr. Maan, we want to understand the current standard of care for ulcerative colitis for moderate to severe diseases.
Thank you, Sanjana, for the kind words and for the introduction. So as far as ulcerative colitis is concerned, I'd like to talk about the most followed guidelines, the AGA, the American Gastroenterological Association guidelines. And in the context of moderate to severe ulcerative colitis, we recently had these Living Clinical Practice Guidelines 2024. And like Dr. Sampath has explained, so what is moderate to severe? Patients with severe symptoms like more than 6 stools per day, frequent blood in stools, Mayo endoscopy score of 2 or 3, high inflammatory burden. He's already talked about, CRP and fecal calprotectin, or poor prognostic features like younger age at onset, extensive colitis. We could have extraintestinal manifestations, hospitalization, or even corticosteroid dependent or refractory disease. So all of this constitutes moderate to severe disease. And as far as the AGA is concerned, it suggests early use of advanced therapies like Dr. Sampath had mentioned, top-down approach, not waiting for the results, but just going hammer and tong for the symptoms with or without immunomodulators rather than a gradual step-up approach. Selection of induction therapy could depend on, because we have multiple options, and like he mentioned, that there's no single answer. So the choice could depend on comorbidities like arthritis, psoriasis, or patient preferences, patient characteristics like age or pregnancy, if whether there's a risk of MACE or infection, malignancy, etc. As far as the first-line induction therapy options include for ulcerative colitis, it could be biologic agents with or without immunomodulators, the S1P receptor modulators, or glucocorticoids. In the context of patients who are naive to advanced therapies, the AGA suggests anti-TNFs, the ones with higher efficacy like infliximab or the anti-integrin vedolizumab, S1P receptor modulators, ozanimod or etrasimod, and even the anti-ILs, risankizumab and guselkumab. For patients who have been previously exposed to one or more advanced therapies, the AGA suggests higher efficacy medications like the JAKs, tofacitinib or padasitinib, or ustekinumab, and other anti-IL medications like risankizumab or guselkumab. For patients experiencing infliximab primary non-response, ustekinumab or tofacitinib are good options, but AGA suggests that biologic combination therapy is a better way to treat, and that would be anti-TNF with immunomodulators. So individuals who are having RA or ankylosing spondylitis, anti-TNFs is a good option. For individuals with psoriasis or psoriatic arthritis, the anti-ILs can be considered. S1P modulators in individuals who have maybe multiple sclerosis, etc. But the use of JAKs is limited to second line in the AGA guidelines. As far as maintenance is concerned, for thiopurines are suggested for corticosteroid-induced remission, whereas it suggests that the therapy that was used to achieve remission should be continued long term for maintenance of remission. That is the AGA guideline on Crohn's, ulcerative colitis.
Thank you, Dr. Man. I think that was a great picture of the current standard of care being followed. With that context, could you also elaborate on the treatment landscape for Crohn's disease as well, Dr. Man?
For moderate to severe Crohn's disease, the guidelines or the AGA guidelines were recently updated in 2025. And moderate to severe disease would be severe pain abdomen, high inflammatory burden, again, corticosteroid-dependent disease, or disease with significant GI involvement, fistulizing disease, deep ulcers, or a CDI of more than 220 to 450. So the patients that fit this profile, AGA again suggests upfront use of advanced therapies. And the selection again would depend on multiple factors. And here in this case, like Dr. Sampath mentioned, patients with fistulizing or penetrating disease would need a different approach versus inflammatory. And here we have for the first line induction therapy options, we have either a glucocorticoid or a biologic agent with or without immunomodulators. So for patients who are naive to advanced therapies, higher efficacy medicines like the anti-TNFs, infliximab or adalimumab or the anti-integrin vedolizumab, and anti-IL therapies, ustekinumab, risankizumab, and mirikizumab are other choices. But AGA suggests that infliximab should be used in combination with immunomodulators. And as far as anti-IL therapies are concerned, risankizumab, mirikizumab, we have guselkumab and ustekinumab, as well as vedolizumab, the anti-integrin. They are suggested for monotherapy. And as far as fistulizing disease is concerned, anti-TNF, probably infliximab in combination with immunomodulator is an excellent choice. For individuals who are exposed to one or more advanced therapies, AGA suggests higher efficacy medications like the anti-TNF adalimumab or the anti-IL agents or the JAK inhibitors or padasitinib. As far as the maintenance therapy is concerned, again, thiopurine monotherapy for corticosteroid-induced remission, and long-term maintenance is suggested to be continued with the agent that induced remission. So that would be, in a nutshell, the AGA suggestions for management of moderate to severe Crohn's disease.
Understood. Thanks, Dr. Mann, for your perspective on the current pharmacological treatment of UC and CD. It was really helpful. Could you please wrap up with your views on the current unmet needs for these two indications?
Yeah, sure, Sanjana. So unmet needs, I mean, Dr. Sampath has already touched upon, and I'll talk about a few more. And this is a very interesting topic because it is of great interest to the patients as well as physicians and the drug developers as well. So, I mean, if I think about Crohn's disease and at the time of diagnosis, if we could have, validated biomarkers that could probably, identify individuals who are at risk when they're in the preclinical stage, because we know that uh, early treatment improves outcomes. So individuals at risk who are still in preclinical stage, it would be wonderful to find out about those patients. And if we can know at the outset what disease phenotype a patient is going to follow, like a fibrostenotic versus fistulizing or only inflammatory, if we have biomarkers for that, that would be great. And biomarkers for prognostication to formulate treatment decisions. Even for disease monitoring, like if there are biomarker panels to inform treatment decisions and identify response to therapy, that would be great because endoscopy is the gold standard, but it has challenges like cost or availability or discomfort to the patient. And in Crohn's disease, fibrostenotic disease is a big challenge for the treating physician. So, if we could have universally accepted treatment protocols to manage strictures and avoid surgery, if there are universal consensus guidelines for endoscopic intervention to manage strictures, and what we really need is large randomized trials to investigate the use of biologics to manage strictures so that we have uh, consensus around how to manage this very challenging part of the disease. And as far as treatment is concerned, we need curative treatment options because right now all we have is lifelong use of advanced therapies for patients with moderate to severe disease. So anything that can help with sparing the steroids and immunomodulators would be great. And in the context of Crohn's disease, we know that almost one-third of patients do not respond to the anti-TNFs, and about one-third end up with secondary non-response of the responders. So a lot of patients need surgery. Up to two-thirds patients may need surgery during their lifetime, and they are on lifelong need for advanced therapies. And similarly for ulcerative colitis, biomarkers again for prognostication and make treatment decisions and determine response to therapy. But here in this case, if we there is a need for curative treatment options again because steroid dependence is a big issue. Patients who achieve corticosteroid remission, approximately 20% still require the corticosteroid therapy after 1 year of use. And the steroid-dependent patients, when they switch to infliximab, only half of them are corticosteroid-free at 12 months. As far as the advanced therapies are concerned, uh, almost half of the advanced therapy naive and experienced patients, they remain non-responders. And 25% of patients who achieve durable remission uh, with the anti-TNFs. And approximately 20% of those responders, they experience secondary loss of response. So that is in brief the various unmet needs that can help in further management of the patients.
Understood.
Sanjana.
Understood. Thank you. Thank you so much, Dr. Mann, for the great insights and perspectives. All right, with that, we'll move on to our next panel expert for today, that be Dr. Gursharan Singh. Dr. Singh has earlier held positions of Senior Associate Director at Dr. Reddy's Labs, Hyderabad, India, and Senior Principal at a New York headquartered global life sciences consulting firm. He has extensive experience across multiple therapeutic areas and domains such as clinical development, medical affairs, clinical regulatory, portfolio strategic consulting, medical writing, and scientific communications for a variety of products across different regulatory authorities. Dr. Singh is also an artificial intelligence enthusiast and the co editor of the textbook Pharmaceutical Medicine and Translational Clinical Research, which is published by Elsevier in the US. So, we would like to welcome you, Dr. Gursharan, with us. And having heard from Dr. Kumar and Dr. Mann about the current treatment landscape and guidelines for the US and the UK, we would like to first hear your thoughts on how ulcerative colitis treatment landscape is going to evolve over the next 5 to 7 years.
So thanks, Sanjana, and thank you very much, Dr. Sampath Kumar and Dr. Mann, for giving insights based on your real experience with gastroenterology space. So as far as the evolution of the treatment landscape is concerned, so I think what we need to see here is that what is the current response? And Dr. Sampath Kumar and Dr. Jasdeep Maan have discussed about the unmet needs. So for example, today, if we look at drug like guselkumab, in terms of the induction response for ulcerative colitis, the clinical remission which takes place at week 12, that happens only in 30% of the patients. And by week 52, it increases to say 60% of the patients. And here I'm talking about the treatment naive patients. When we look at the patients who are treatment experienced, it is 20% at week 12 and it becomes around 40% at week 52. So this means that there is significant unmet medical need. And autoimmune disease area is one which is beyond oncology. This is one area which is likely to benefit the most from biologics. And most of the work I have done till now has been in the dermatology segment where we have worked on psoriasis and atopic dermatitis. And these fields of psoriasis and atopic dermatitis, which are also autoimmune disorders, they have been completely revolutionized during the last 20 years. And I'm expecting the same revolution to occur in each and every autoimmune disorder over the next 2 to 3 decades. And specifically, when we talk about ulcerative colitis and Crohn's disease, apart from unmet need in terms of improving the response, in terms of the clinical remission, in terms of the endoscopic remission, one very important thing is that we do not have the validated patient-reported outcomes here. So what challenges patient is facing, that challenge does not actually get reflected into these endpoints. And these endpoints like Mayo score and the Crohn's disease activity index, these are actually composite indices. Whenever you have composite indices in any disease, it becomes very challenging to demonstrate benefit in that disease of any kind of therapeutic intervention. So I think one is that we need the proper validated patient-reported outcomes here. Another important thing is that the focus has to be on the overall quality of life of the patient. How do we how do we prevent progression of the disease? How do we minimize the risk of cancer? How do we minimize the risk of lymphoma for the patients who are taking these things? And particularly the fulminant cases in ulcerative colitis. So how do you manage this? Now, considering all this, the way I think future is going to evolve is that the role of biologics and the role of JAK inhibitors is going to start much earlier than it has been during the past few years. Today, the efficacy and safety of many of these biologics is satisfactorily established, though obviously in long term, as Dr. Sampath said, we do not know, but definitely for any new therapy, you have to take a decision based on benefit risk profile. A very interesting development which has happened is that guselkumab in combination with golimumab has shown superior efficacy both in terms of clinical remission as well as in terms of endoscopic remission in ulcerative colitis. And So these are two different mechanisms of action. On one hand, we have got IL-23. On the other hand, we have got TNF alpha. Then we have several other mechanisms of action which have a role to play. So over the next few years, as many of these drugs will go off patent, many of these biologics will go off patent, there is a possibility to evaluate multiple combinations. But again, the challenge which comes here is that already biologics are very expensive, and then biologics have their own safety profile. So when you combine them, what happens to the health economic outcomes? What happens to the safety outcomes? So all these things will have to be looked into when the future landscape will be evolving towards combination therapy. And if combination therapies work, why not go for bispecific antibodies or trispecific antibodies, which can target receptors simultaneously? So those things have already started happening in other therapy areas. In oncology, in psoriasis, we have a very interesting bispecific antibody which is doing wonders. So I think that can very well happen in this ulcerative colitis also. And as Dr. Sampath Kumar also mentioned, the question is about access and affordability. These biologics are really expensive. So biosimilars are going to play a very important role in improving access, improving affordability. In terms of the overall market, because the biosimilars will significantly reduce the price, so the value of the market may not go up so high, but in terms of volume, the market is definitely going to progress. And when we talk about the specific therapies, one of the therapies, obefazimod, which has shown some benefit. It is actually an oral small molecule micro RNA 124 enhancer, which actually is involved in the regulation of immune system. And in phase 2b clinical trial, obefazimod has shown significant benefit, which obviously it is not a direct comparison against any of the approved therapies, but it looks quite attractive. And the phase 3 study is ongoing. The data will be available next year. In terms of induction, it seems to be almost as good as guselkumab, but in terms of maintenance, maybe this might further improve the efficacy. So these are some of the things which are likely to happen over the next 5 to 10 years. And apart from that, definitely there is going to be role of artificial intelligence. There is going to be role of nutrition in conjunction with artificial intelligence, precision medicine, all those things which we can discuss separately. So that's about ulcerative colitis landscape evolution.
Thanks, Dr. Gursharan. Thank you so much. This was providing your perspectives and great thoughts there. I was wondering, what about Crohn's disease, and how do you think the treatment landscape will evolve there?
Now, as far as the clinical development is concerned, and as far as the industry is concerned, Crohn's disease and ulcerative colitis, they are not very different. So again, in this case, most of the drugs which get approved for ulcerative colitis, which are already approved or which will get approved later, sooner or later, they also get the Crohn's disease indication. And Crohn's disease, if you look at the induction phase, if you look at, for example, the response of guselkumab, in induction phase itself, the response is somewhere around 55%, and I'm talking about clinical remission, versus ulcerative colitis, where it is just 30%. But when we talk about the maintenance phase, when we talk about the week 50, 48 or week 52 data, it is almost the same. It is 65% versus 60% in ulcerative colitis. So in case of Crohn's disease, I think one good thing which has already happened is that recently FDA has come up with a guideline, and it doesn't apply specifically to Crohn's disease, that going forward, you will not need two double-blind randomized placebo-controlled studies, and even a single study can be sufficient to approve. And it has already happened in case of Crohn's disease that mirikizumab, which Dr. Jasdeep also mentioned, mirikizumab has already been approved for treatment of Crohn's disease based on a single study. Now, this was relatively challenging because in the same study, you have patients who are biologic naive, and in the same study, you have patients who are biologic experienced, but that has happened. Now, some bispecific antibodies, as I mentioned in case of ulcerative colitis, some bispecific antibodies are already being investigated in Crohn's disease at preclinical level. And just like we have the combination therapy in ulcerative colitis, the same can also work for Crohn's disease. And there are multiple mechanisms of action which are helping Crohn's disease. So we have TNF alpha, we have IL-12/23, we have got integrin alpha-4 beta-7, we have IL-1 beta, we have IL-17. So when we target all these together, so bispecific antibodies or multi-specific antibodies may have a role to play. So overall, combination therapies, bispecific antibodies, antibody drug conjugates. These are the kind of the things which I think will help Crohn's disease also going forward.
Understood. Understood, Dr. Singh. No, thank you for that. And since you already have been into clinical development, could you also please throw some light into the clinical development guidelines or the framework in these two indications, please?
Yeah, so for both ulcerative colitis and Crohn's disease, we have the guidance from the US FDA, and we also have the guidelines from the European Medicines Agency. So the European Medicines Agency guidelines are the final guidelines, and they have been deliberated over several years. And finally, in 2019, the guidelines were released. US FDA guidance is currently in draft stage. It is there since 2022, but it is common for US FDA guidances to remain in draft stage. So when we talk about clinical development, basically I'm going to tell you about the study population, about the endpoints, about the study design, about the comparators, about the study duration. So ulcerative colitis and Crohn's disease, there are many commonalities. But first, let us discuss where the differences are. So number one, in terms of the study population. So study population, we have that in case of ulcerative colitis, you are going to select patients based upon the Mayo score. Mayo score have got 4 components, and one of the component of Mayo score is the physician global assessment. Now, physician global assessment is something which is a subjective component. So US FDA was not very comfortable having a subjective component because it leads to confounding, and therefore they modified the Mayo score, which is without the physician global assessment. So patients are selected either based on modified Mayo score from a US FDA perspective, or based on the Mayo score as such, based upon the European Medicines Agency perspective. And in terms of the primary endpoint, for ulcerative colitis, you need to demonstrate that from an FDA perspective, you have a single primary endpoint, and you basically need to demonstrate that the modified Mayo score has been reduced to 0 to 2. On the other hand, EMA, the European Medicines Agency, has got two co-primary endpoints. One is based on the endoscopic component, other is based on the non-endoscopic component of the Mayo score. So for both of them, it has to be reduced to 0 to 1. And if it is there 0 to 1, then that co-primary endpoint has been met. So overall, there is not much difference between the US FDA and EMA, but still they have their own way of looking at things. Now, when we talk about Crohn's disease, and Dr. Mann also mentioned, we have got the Crohn's disease activity index. So Crohn's disease activity index is based upon several clinical and lab parameters. So that is the criteria to select patients from a US FDA perspective. EMA is more inclined towards patient-reported outcomes. So EMA says that instead of looking at the lab parameters, focus more on the symptoms. So there is something called as the PRO2 and PRO3 basis, which patients can also be selected in the clinical studies. And then apart from that, perhaps as Dr. Sampath Kumar mentioned, endoscopy is the most important thing. So you have to look at the endoscopic scores. There are a variety of endoscopic scores which are considered. So depending upon the endoscopic score cutoff, which vary depending upon which endoscopic score we are considering, the patient would be selected in trials for moderate to severe Crohn's disease. Now, when we talk about the primary endpoint for Crohn's disease, both FDA and EMA talk about a co-primary endpoint. So it is clinical remission or it is symptomatic remission, and it is also the endoscopic remission. In terms of endoscopic remission, it has to come down to 0 to 2. And in terms of the clinical remission, when we talk about the clinical disease activity index, it should come down to less than 150. And in terms of the symptomatic remission, the PRO2, which is there, that should come down to less than 8. So this is about the population, this is about the endpoints. Now, in terms of the design, it is the same. The requirement is same, both for ulcerative colitis and Crohn's disease. So there are two approaches. One, you can have induction followed by maintenance. So basically, the patients who achieve induction response, they are re-randomized. Half of them, they continue with the active therapy, and half of them, they go into the placebo arm. So in a way, they are withdrawn, and then you compare the data. So basically, you have two endpoints in this kind of approach. You have one endpoint for the induction phase, you have another endpoint for the maintenance phase. And the other approach is treat through week 52. So basically, no re-randomization will occur. Patients who have been randomized, they will continue till week 52. And then at week 52, you are going to look at the primary endpoint. So that's about the study design. In terms of the data, so both US FDA and European Medicines Agency requires 1 year data minimum when you have to submit the dossier. So you need to include data for both the induction and the maintenance phase. In terms of the comparator, so these are basically placebo-controlled studies, but they are also supposed to have an active comparator. Now, EMA says that if you want the drug as a first-line, active comparator is mandatory. This is somewhat different from FDA. So FDA is fine with placebo-controlled studies, and FDA also requires an active comparator. With an active comparator, depending upon the profile of the drug, the sponsors may want to demonstrate superiority if they are confident. Otherwise, a non-inferiority with a proper margin which has been agreed with US FDA is also something which is accepted. So this is, in a way, a kind of brief summary of the clinical development guidelines we have for ulcerative colitis and Crohn's disease for the two leading regulatory agencies of the world, which we consider while designing our clinical studies.
Understood, Dr. Singh. That was very helpful. And since you are one of the AI enthusiasts amongst us, so my last question to you is regarding the role of artificial intelligence and how do you think AI will help in clinical practice or clinical development of biologics for IBD?
Artificial intelligence is no doubt one of the most transformative force for mankind. I think people have said that even discovery of fire or discovery of wheel did not have the same impact which artificial intelligence, particularly the generative AI and agentic AI, are going to have. So many reports are coming from McKinsey, from PricewaterhouseCoopers. Everybody is talking about artificial intelligence. And as Dr. Sampath Kumar said, when I am talking about artificial intelligence, it is to augment the human contribution. It is with human oversight. In the field of medical, in the field of health, artificial intelligence cannot work independent of the medical judgment or independent of the human oversight. Now, definitely, artificial intelligence is rewriting both the clinical development and the clinical practice playbook. So basically, we have various technologies. We have the machine learning, we have the deep learning, we have the natural language processing, the computer vision, generative AI, the agentic AI, and so on and so forth. And in terms of how artificial intelligence is going to be used in clinical trials, I think there are 4 areas. Number one is the patient recruitment. So looking at the electronic health records and looking at the real world data, which is very huge data lying across, with the help of artificial intelligence, natural language processing, it is possible to identify the eligible subjects for a clinical trial very quickly. Otherwise, the same thing will take a lot of time when you have to look at the data of individual patients manually. So that is one contribution. Second is in terms of the trial design. So basically, there are several cases where the therapies are not successful and the clinical trials, they fail. And when they fail at a much later stage, when a lot of sample size, when a lot of patients have already been recruited, then it's a huge loss to the sponsors. So with artificial intelligence, based upon very minimum data, an interim analysis can be done. And we get some idea whether this drug is going to work or not. And if it is going to work, a sample size re-estimation can be done. Then there is something called as the response adaptive randomization. So if you see that this drug is working, you shift patients towards that drug in the clinical trial rather than wasting the patients on the other drug, because ultimate objective is to see which drug is working and not just allow some drug to fail, because that is not going to help. Then we know that placebo arm has been there, but the placebo arm actually doesn't help the patient. So is it possible that instead of having a placebo arm as an internal arm in the study, we have an external synthetic arm based upon the data coming from artificial intelligence? So those kind of discussions are also happening. Another important thing is about the AI-driven centralized monitoring. So all the data which is there, which is generated in the clinical trial, so monitors, they are reviewing that data. And there might be certain signals that the patient is at risk, the patient safety is at risk, or the GCP compliance is at risk, the sites are deviating. So artificial intelligence can detect some subtle changes which can help us take appropriate mitigation measures much early so that we don't ruin the investment which has been done. And very important thing here is about the role of artificial intelligence in the assessment of endoscopy and assessment of histopathology, as Dr. Sampat Kumar also mentioned, the way it is helping the radiologist. Similarly, once you have the endoscopy results, so you have a huge clinical trial being done across the world. So you have a centralized reader in order to minimize the uh, variation. So with the help of artificial intelligence, this inter-observer variability can be reduced. And if this variability is reduced, we will have more genuine outcomes coming from the clinical study. So these are some of the things in terms of the clinical trial. Now, in terms of the clinical practice, so clinical practice, artificial intelligence is going to help predict the outcomes. It is going to help in precision medicine. It is going to help us which patient is going to develop flare so that we modify the treatment accordingly. Any up titration is required, any change in the therapy is required, that can be done. But for this, you need data. Now, from where do you get data? So there are multiple approaches which are being explored today. And in US, for example, they have come up with one app is there called as the My IBD app, which the IBD patients are able to download, and then they are going to enter their symptoms, they are going to enter their diet, they are going to enter the activity. And this data is going to the healthcare provider, to the gastroenterologist, as Dr. Sampat Kumar also mentioned, that this way they are able to, they get alerts and they know where they need to intervene. Similarly, now they are looking at wearables. For example, your Apple smartwatch, Fitbits. Then there are rings. So basically, these wearables are collecting data like heart rate, variability of heart rate, oxygenation. And if there is any kind of sign of inflammation, that can be detected much earlier. And they can distinguish between GI inflammation versus non-GI inflammation. And thus, there are reports that up to 7 weeks ahead of the flare, you start getting some signals which can be analyzed with the help of some artificial intelligence software. And this research has been done at Mount Sinai. At University of Chicago, they are looking at some sweat sensors, and they are looking at taking the photograph of the stool, and basis that artificial intelligence is able to analyze whether there is any indication that this subject is going to develop flare over the next few days or weeks. And thus preemptive modification of the treatment can be done. So these are some of the things which are being discussed. And the field of artificial intelligence is growing very fast. A lot of investment is being done across industries. Healthcare is definitely one field which is going to benefit. So obviously the healthcare providers, regulators, the government, non-government organizations, pharmaceutical companies, they have to work together to see how best this wonderful technology can be leveraged. But as many other sectors have already started leveraging artificial intelligence and improving their efficiency, this is one field where improving the efficiency will benefit mankind like anything. And so I think this opportunity nobody would like to miss. Despite all the hurdles and challenges in terms of transparency, in terms of explainability, in terms of ethical concerns, in terms of oversight, I'm sure AI application will continue to increase in this field and will definitely improve the outcomes.
Wonderful. Thank you. Thank you, Dr. Singh, for providing such interesting insights on the aspects of AI. And thank you for your time. So we'll move on with the discussion, and our final panel expert for today, dietitian Divya Tulsen. So Ms. Divya provides evidence-based medical nutrition therapy and personalized dietary interventions across diabetes, thyroid disorders, PCOS, NAFLD, and gastrointestinal disorders. She's also an alumna of NIN ICMR Hyderabad and Punjab Agriculture University, Ludhiana. So, welcome, Ms. Divya, and we are very honored to have you today with us. So,
Thank
yes, we would like to understand from you, Ms. Divya, how diet
yes.
therapy basically acts as an adjunct to medical treatment to improve the remission rates or maybe reduce the flare frequency in IBD.
Yes. Well, today we have strong evidence-based researches that supports the fact that diet therapy in IBD is clinically relevant adjunct to medical therapy because it directly influences the gut microbiome, the intestinal permeability, as well as the inflammatory pathways. So today, the STRIDE guidelines, uh, they are emphasizing on majorly four types of diets that have shown significant reduction, significant uh, contribution in inducing and maintaining the remission in IBD patients at all severity levels. So let's talk about these four types diets. So the first one is exclusive enteral feed nutrition with using liquid formulations, basically polymeric formulas, and it has been uh, found to be effective therapy in both clinical remission and having as well as endoscopic remissions in uh, moderate to severe uh, Crohn's patients, especially in pediatrics. So with the little modifications, we have now shifted towards to our next diet, that is Crohn's exclusion diet along with partial enteral nutrition. So here, this diet really see a better compliance, and also clinically it shows that it is effective in producing the significant outcome in terms of clinical as well as endoscopic remissions in mild and moderate cases of Crohn's active cases. So, but the one benefit that we have of Crohn's exclusion diet along with the partial enteral nutrition is here we are not totally dependent upon the enteral nutrition, and including the whole food like bananas, cooked rice, cooked fish, and chicken. It allows basically, to introduce 50% to met our 50% of nutritional requirements from enteral nutrition, and the other 50% is coming from a whole food. So it is seen that it has also um, uh, used sometimes as a salvage therapy for when the patient is having loss of response to biologic therapies. So overall, these two therapies are basically which have a strong evidence in pediatric Crohn's cases. And then moving on to the Mediterranean diet, which has again uh, quite strongly supported by both AGA and STRIDE guidelines. They say that until it is contradicted, until this contradicted, the patients, the IBD patients who are able to tolerate the oral diets, they should always include or they should always be advised to uh, follow Mediterranean diet, which includes wholesome foods from like including fruits and vegetables to monosaturated fats like olive oil and complex carbohydrates and lean proteins, less on unprocessed foods. So this type of diet is again has a strongly support of short term RCT trials, which shows it is quite very effective in not only having the clinical remissions, but also it founds that it keeps fecal calprotectin levels in check during remission. So, and it also has holds additional benefits, showing cardiovascular benefits, metabolic syndrome, and it reduces the risk of cancer also, especially during the remission phase in both ulcerative colitis and Crohn's patients. And then we are discuss we have another guidelines which are mentioned by STRIDE in STRIDE guidelines is our low inflammatory, low residue, low fiber diet, which are generally applied during the uh, flare up times, because it shows that it really protects the gut lining, and it does not we do not want to add a mechanical stress during the flare up time already. So these diets which are low in fiber really helps in both ulcerative colitis patient as well as Crohn's patients during their active phases. So coming to there is another evidence-based diet, that is a low FODMAP diet. Generally, it is highly spoken about in social medias and everything. But today, research is showing that definitely it is giving us some symptomatic relief for our IBD patients who display IBS symptoms as well, like bloating or acidity or nausea. But in long term, it is not effective in showing in any biochemical or uh, endoscopic remission. So coming to the fact that we have so many diets which are strongly supported, uh, but there is no single diet for IBD. And during the intervention, we have to just come up with a well thought intervention strategies plan put together, which may need or require to change as and when required. So, and so having said that, there may be some situation like severe situation like prolonged ileus or high output fistulas, or when the digestive tract or GI tract is not working at its potential level, then we might have to resort to that parenteral nutrition also. But as AGA guidelines suggest, that we should always try to you know come back to the oral intake as soon as possible to avoid any further complications. So diet cannot replace the medical nutrition therapy. It only what it is doing is it is enhancing the clinical outcomes by improving the internal environment in guts in internal environment, and making it more stable and less reactive for healing.
Understood. Understood, Ms. Divya. I think this is very helpful, and I'm sure for a multidisciplinary, holistic treatment approach, I'm sure diet plays a very crucial role in IBD. So, thank you for your perspectives on that. Also, I would like to understand from you, Ms. Tulsen, how can targeted dietary supplements and functional fibers support mucosal healing in IBD management?
Okay. So strike 2 guidelines in phase 4 generally emphasize on mucosal healing to be a new therapeutic target, and educate nutrition supplementation definitely can support this goal. So the targeted supplementation of omega 3s or vitamin D, vitamin B12, iron, and zinc, and especially addressing the other micronutrient deficiencies that occur due to the drug therapy, like patients on corticosteroid therapy may see the deficiency of calcium, magnesium, potassium, and like especially the folic acid deficiency, which are seen mostly in patients who are on methotrexate and sulfasalazine therapy. So all correcting all these micronutrient deficiencies help us definitely with the immunomodulation, and improving the gut integrity and enhancing the epithelial repair. So this is the one thing. And the second thing that we really cannot stress enough is introduction of prebiotic foods, which are high in soluble fibers like psyllium, or that is partially hydrolyzed guar gums, or it may be resistant starch, which may be admitted in during the remission phases, so that we could reduce the flare frequency and relapses over a long period of time. Yes.
Understood, understood. Thank you. And finally, Ms. Tulsen, we also want to understand how can the healthcare systems practically integrate these nutrition therapy that you talked about in the IBD management?
Okay, so healthcare system can integrate nutrition very effectively with by aligning itself with stride to treat to target model. So when the targets are sustained remission, improved quality of life, and reduction of flare frequencies and relapses, then the nutrition is is kind of plays a supportive role, uh, plays kind of a supportive role in whole this scenario. And when basically what it means in a real scenario is routine screening checkups by a dietitian, early referrals uh, to a trained clinical dietitians, and well as follow-ups during flares up and as well as remission phases. So when a dietitian collaborates with a gastroenterologist, whether in the physical setting or in digital care system, it makes sure that the patient is, getting evidence-based guidance, not which not only reduces the fear around food, but it also makes sure that there is an improvement in tolerance and adherence to the therapy. So the integration of nutrition will also make sure that healthcare systems are not having sharing the like we are having low we are able to reduce the healthcare burden, and and seeing nutrition in IBD is not as a optional care, but as a practical patient-centered approach, will make the difference and will actually align with the um, treat to target model of stride to guidelines also.
Understood. Understood. Thank you, Ms. Sultan, for all your perspectives. This was really helpful. And with this, then, I'd like to sincerely thank all our panelists today for sharing their expertise and perspectives from clinical practice to research, innovation, and diet therapy. Crohn's and Colitis Awareness Week reminds us that these conditions are not just medical challenges, but human ones. Awareness, empathy, and innovation are key to improving lives. Whether you are a healthcare professional, a patient, or a supporter, I hope you leave today with renewed commitment to raising awareness, supporting research, and advocating for better care. Let's carry forward the spirit of awareness and action beyond this week.